Hello.
Yes, I can hear you.
Yeah. So it's my proud privilege to present a brief biodata of Madam uh, Dr. Rashmi Vyas, Vice President Intel, Senior Director, Famer, a division of Intel, Philadelphia, USA. So if you look at her title as a Vice President Intel and Senior Director of Famer Global, Dr. Vyas has two main areas of responsibility. As a Senior Director, Famer Global leads Famer Global's its strategic initiative and program in collaboration with other members of FAMER team. As a Vice President in Health, Dr. Vyas connects FAMER Global with the strategic vision, goals, and values of Intel and forest coordination, collaboration, and integration across all the FAMER focal area and within Intel in partnership with the Executive Director FAMER. Dr. Vyas contributes her expertise in medicine, health professional education, and understanding of international culture of FAMER program, which is geared towards healthcare education and workforce development in collaboration with international partners. Prior to joining FAMER, Dr. Vyas was a professor at Christian Medical College, Vellore, India, and led many educational innovation at institutes and national level. Dr. Vyas received her MD degree from India and Masters in Health Professional Education from UIC, USA. She has been awarded the fellowship in HPE from Famer Institute, Philadelphia, USA, and fellowship in leadership from Executive Leadership in Academic Technology and Engineering, Drexel University, Philadelphia, USA. I think this is only the iceberg of Madam's introduction. Thank you very much, Dr. Bedi, for giving me this opportunity. Over to Madam.
Thank you, Chinmay. I would like to share my screen. Please confirm if you can see this.
Yes, we can see.
All right. Good morning, good afternoon, good evening, everyone. Thank you to MEU India Group for inviting me to speak with such a diverse group of educators, all dedicated to advancing health professions education across disciplines and contexts. I first met Dr. Rita Sood in 2003 when I started my journey in health professions education. She was a FAMER Fellow. She was my mentor, friend, and collaborator in advancing HPE in India and globally. Today, I'm both honored and humbled to give the Rita Sood Memorial Oration. I'm Dr. Rashmi Vyas, as just introduced, Vice President at Intel and Senior Director, FAMER Global. Intel is the overarching organization, and both FAMER and ECFMG are divisions of Intel. My primary role is to provide oversight to the FAMER Global programs, including the International FAMER Institute and FAMER Regional Institutes. Our topic today, integrating global best practices with local contexts, advancing excellence in health professions education, is a question that educators around the world grapple with. We live in an era of unprecedented access to knowledge with innovations in competency-based education, technology-driven learning, and faculty development emerging from institutions worldwide. But the real challenge is not just knowing what works globally. It is making sure it works in our unique contexts. In many ways, today's presentation builds on the legacy of Dr. Rita Sood, a visionary in health professions education who was deeply committed to improving how we train the next generation of healthcare professionals. Throughout this presentation, we will explore key global trends, examine how they can be adapted effectively for different local settings. My hope is that by the end of our time together, we will not only appreciate the balance between global and local in health professions education, but also take away practical steps. Here's the roadmap for today's presentation. Let us ask ourselves 4 questions: what, why, how, and when. First, the what. What are global frameworks in health professions education? We will explore the role of some of the global frameworks in shaping HPE. Next is the why. why global models need local adaptation. We will discuss the need for globalization, how we can balance the global standards with local healthcare and education needs. Then comes the how. How does FAMER integrate global practices with local context? We will look at some of the FAMER programs and how it does localization through faculty development and curriculum adaptation. And finally, the when. When do these strategies create impact? We will look at some practical applications. Let us begin by reflecting on understanding the role of global frameworks in shaping health professions education. Health professions education, or HPE, as I will refer to it going forward, is guided by several key frameworks that define competencies, learning outcomes, and accreditation standards. Today, we will focus on three major ones: CanMEDS, ACGME competencies, and WIFME standards. CanMEDS, or Canadian Medical Education Directives for Specialists, was developed by the Royal College of Physicians and Surgeons of Canada. It outlines 7 essential roles that physicians must fulfill. First is medical expert, which is the central role, applies medical knowledge to patient care. Second is communicator, effectively exchanges information with patients and healthcare teams. Third is collaborator, works with healthcare professionals to provide quality care. Then is leader, engages in resource management, system improvement. A health advocate promotes health and well-being at individual and community levels. A scholar engages in lifelong learning and research. A professional demonstrates ethical practice and commitment to medical standards. So if we were to apply, it would look something like this. A physician using CanMEDS principles will not only diagnose and treat diseases, but also communicate effectively with patients, work in interdisciplinary teams, and advocate for public health policies. The next one, ACGME, Accreditation Council for Graduate Medical Education. This one is located in USA. ACGME defines 6 core competencies required for all medical residents in accredited programs. First is patient care, that is, provide compassionate, appropriate, and effective care. Second is medical knowledge, demonstrate up-to-date evidence-based medical expertise. Third is practice-based learning and improvement, continuously self-evaluate and improve. Fourth is interpersonal and communication skills, that is, foster clear and professional interactions with patients and colleagues. Fifth is professionalism, exhibit ethical behavior, respect, and responsibility. And system-based practice, understand and improve the broader healthcare system. An application would be a medical resident trained under ACGME standards must not only excel in clinical practice, but also engage in quality improvement initiatives and system-based care to enhance patient outcomes. The third one, the World Federation for Medical Education, WIFME, it is an international organization headquarters in France, dedicated to improving the quality of medical education worldwide. What WIFME does is it sets global standards for basic medical education at the undergraduate level. It has 8 standards. And the postgraduate medical education, that is the residency training and continuing professional development, that is lifelong learning for physicians, both with 9 standards. If we were to take a case study, how are WIFME standards implemented in India? As all of you know, in India, medical education was historically regulated by the Medical Council of India. And one of the challenge was in ensuring quality across the 600 plus medical colleges. So to align with global best practices, the National Medical Commission adopted WIFME accreditation standards. And what were the things that were done? First was curriculum reform. So the MBBS curriculum was revised to integrate competency-based medical education, aligning with WIFME's focus on outcome-based learning. Second was faculty development. Faculty trainings were introduced to improve different aspects. You have so many faculty development programs going on. The third is accreditation and quality assurance. Medical colleges had to meet the WIFME's accreditation benchmarks. It allowed for international recognition. So India's accredited body sought WIFME recognition. We know that NMC was recognized by WIFME, allowing Indian medical graduates to qualify for international licensing. So the potential impact are improve the teaching quality and assessment standards, strengthen student learning experience, and international mobility. If we were to compare all three, it shows that the primary focus for WIFME International is setting global accreditation and quality standards for medical education. CanMeds, which is from Canada, is defining competency-based roles of physician, and ACGME from USA is establishing competency-based training for medical residency programs. The key differences and similarities: WIFME sets global quality benchmarks, ensuring medical education institutions meet international standards. Its application is international. CanMeds focuses on physician competencies, shaping how doctors are trained with a well-rounded skill set. Its application is in Canada with global influence. ACGME emphasizes structured competency-based training, particularly for graduate medical education. Its application is in USA and with global influence. All three influence global medical education, but WIFME focuses on accreditation, while CanMed and ACGME shape curriculum and training. What I would like to do is, I would like to take a moment for you to reflect on which of these frameworks is most relevant in your context. Are any of these currently used in your institution? If you are comfortable to do so, please put your answers in the chat function. Otherwise, we'll just take a breath for a minute, for a moment, and reflect on these three frameworks. Okay, I'm getting some answers. For some, it's being used, mainly the WIFME. For some, it's not being used. Again, WIFME. For some, it's close to CanMeds. WIFME. Thank you for sharing your reflections and sharing your thoughts. So having said that, what we'll do now is look at the strengths of these global frameworks in HPE. And the primary strength of these is to ensure quality and consistency through, number one, quality assurance and accreditation. So they ensure minimum educational standards for medical schools and health profession schools worldwide. Second is competency-based learning, define clear learning outcomes, such as in CanMeds and ACGME competencies. Third is international recognition and mobility. It allows graduates to qualify for global licensing exams. Fourth is evidence-based education practices. It encourages innovation in teaching and assessment, promotes research-driven curriculum development. Fifth is standardized patient care and safety, trains physicians to follow global best practices in clinical care, enhances patient safety and healthcare systems efficiency. While these global frameworks are invaluable for ensuring quality and consistency, the challenges of global frameworks in HP education are primarily one, in context mismatch, and second, in implementation barriers. How does that happen? First point is one size does not fit all. Global standards may not align with local healthcare priorities, disease burdens, or resource availability. They often fail to account for local variations in specific health challenges, resource constraints, and cultural context. For example, a global standard might emphasize advanced diagnostic competencies, but in some regions, the pressing need may be foundational skills in managing endemic diseases or community-based care. In addition, local healthcare priorities often differ. In some regions, maternal mortality is a priority, while in others, it would be aging populations, and so on. In addition to this, there are infrastructure and resource constraints. Many low and middle income countries lack the facilities, faculty, and technology to implement global frameworks effectively. The third piece is faculty training and readiness. Educators may lack exposure or training in different aspects of global standards. Faculty often struggle to contextualize global standards for local relevance in some instances. Then comes the regulatory and policy barriers. Aligning global frameworks with national accreditation policies can be complex and slow. And then comes cultural and contextual differences. Teaching methods, assessment, expectations professionally vary across regions, making direct application of global models challenging. So now that we have seen both the strengths and challenges of global frameworks, let us discuss how we can balance these models with local needs through the concept of globalization. So globalization, it is a need for local adaptations that retain global relevance. So to ensure quality and consistency while addressing the contextual mismatch and implementation barriers, these things highlight the need for local adaptation that retain global relevance. The concept of globalization has been introduced to address this, emphasizing the integration of global frameworks with local relevance. Look at the food industry. The McDonald's burger and pizzas have undergone transformation in India. And what we have is spicy veggie burgers, paneer makhani pizzas, tandoori pizzas, and so on. Similarly, in health professions education, globalization involves ensuring that global standards and frameworks are thoroughly aligned to address the unique healthcare and education needs and priorities of local contexts. So, what is this globalization? Think globally, act locally. So, globalization is global distribution of ideas. Localization is ideas and context specifically made for local needs. And when these are integrated, we get globalization, which incorporates global concepts to local regional needs. As we have seen, the key challenge is one size does not fit for all. Global frameworks provide a strong guidance, but they are often designed based on the needs and resources of high income countries. In many cases, directly applying them without local adaptation leads to challenges in implementation. For example, CBME requires frequent workplace based assessments, but in low resource settings, faculty shortages, this may be challenging. So there are several challenges which make direct implementation of global frameworks difficult. Some of these are different healthcare priorities. We already talked about the variation in the disease burden. For example, CanMeds emphasizes chronic disease care, while low LMICs focus on infectious disease. So the solution is that training should reflect local epidemiology and patient needs. Next is infrastructure and resource constraints. So the technology dependent teaching methods, high-end simulation may not be feasible everywhere. So the answer is using low-cost alternatives. Faculty training and readiness. So faculty may be unfamiliar with some of the global standards. So the solution is faculty development programs to support gradual transition. Cultural and educational differences across regions may be some barriers. So blended approaches are coming up. So imagine you are implementing a global assessment method in a setting where faculty are used to traditional exams. What challenges would arise? I'm sure you all have gone through these as educators. So think about it. So rather than adopting models as they are, we must tailor them to local needs. And we talked about this process being localization. And the key strategy to do that is contextualization. And how do we do that? It's through curriculum adjustments, align global competencies with local disease burdens, flexible assessments, modify exams and assessments to match available resources, and faculty development. This is a recurrent theme to train educators in context appropriate teaching methods. Let's take a moment to reflect, what I will show you is I have 6 questions. I tried to put them as a multiple choice, one to choose one best answer. Uh, Please don't judge the quality of the MCQs. The purpose is not well-written MCQs, but just as a reflection on what we have been listening to and discussing on this. Feel free to put your answers in the chat function. And so the first question is, what is a global framework in medical education? There are 4 options. Please choose one. You can put the answer in the chat function or just make a note of it. I would encourage you to put in the chat function if you're able to, so others can also see. Question 2, why should global education models be adapted to local needs? 4 choices, choose one. Okay, moving on. Question 3, what is the primary goal for WIFME, World Federation of Medical Education? 4 choices, choose one. Question 4, what is a key benefit of CanMeds in medical education? Again, 4 choices, choose one. Okay, moving on. 5th question, why is faculty development important for adopting global standards? 4 questions, choose one. 4 options, choose one. And the last one, what is the concept of globalization in medical education? That's the 6th question. 4 options, choose one. Okay, what I'm going to do is I will show the answers to you now. The yellow highlighted are the correct answers. Question 1, what is a global framework in medical education? It's a standardized model defining competencies, accreditation, and quality assurance in medical education worldwide. The correct answer is A, 1A. Question 2, why should global education models be adapted to local needs? The correct answer is also A, because every country has unique healthcare challenges, resource availability, and cultural considerations. Question 3, our correct answer is B. What is the primary goal of World Federation of Medical Education? To provide international accreditation and quality standards for medical education. 4th question, the correct answer is A. What is a key benefit of CanMeds in medical education? It defines specific role and competencies physicians should develop. 5th question, answer is A. Why is faculty development important for adapting global standards? To train educators in student-centered learning and competency-based assessment. And the 6th question also answer is A. What is the concept of globalization in medical education? Combining global best practices with local adaptations. So all those who got all the correct answers, wonderful. You know it all. Those who did not get all correct, now you know the answers, so that is also wonderful. So on that note, Let me share some examples. We have seen why global frameworks need adaptation to fit local healthcare priorities. I will share examples of FAMER Global Faculty Development, two programs, the FAMER Institutes and the FAMER Competency Based Education. Many of you may be familiar with these programs. So, by integrating global best practices with local realities, FAMER empowers health professions educators to implement meaningful context driven change. I'll share a little bit quickly about the two programs, and then we'll look into the globalization aspect. So I'll just retell the story of the FAMER Institute. FAMER Institute was launched in 2001 by FAMER in Philadelphia as a part-time 2-year global faculty development fellowship in HB education, leadership, and community building, consisting of online component and 2 to 3 weeks of on-site experience. With the onset of pandemic in 2020, it pivoted to a fully online program and is now called the International FAMER Institute, demonstrating a successful pivot. Once the first few cohorts of FAMER fellows graduated from the International FAMER Institute in Philadelphia, USA, and these are the first cohorts 2001, 2002, 2003, 2004. Some of you are here in the picture. So once the first few cohorts graduated, something very interesting happened. They reached out to FAMER and said that there is a need to advance health professions education in their regions. Thus was born the concept of FAMER Regional Institutes, and the first one was established in 2005 in St. GS Medical College, Mumbai, India, and right now they are celebrating their 20th anniversary. Over 2 decades, the International FAMER Institute expanded, leading to formation of FAMER regional institutes located globally, resulting in more than 2,000 FAMER fellows from 59 countries, forming a vibrant global network of HB educators. As many of you know, India has 4 FAMER regional institutes and more than 800 fellows to date. FAMER used an adapted hub and spokes organizational design to develop the FAMER Regional Institutes. The model features FAMER Regional Institutes as spokes relating to International FAMER Institute as hub and to each other. The model fostered mutual partnerships and collaboration, and keeping in the spirit of globalization, FRIs adapted the global FAMER curriculum to local needs. So that's very briefly about the FAMER Institutes. The next program is the FAMER Competency-Based Education, or FACE as we call it. In the needs assessment study conducted by FAMER in 2019, FAMER's global community identified professional development in competency-based education as the topmost need in health professions education. So in response, FAMER launched the pilot phase from Philadelphia in 2021 with 20 participants from India. The participants were faculty who taught in the 4 FAMER regional institutes in India. And as you know, the 4 institutes are located in Ludhiana, Mumbai, Manipal, and Coimbatore. So this program it was offered as a 1-year virtual professional development program in competency-based education for global health professions educators. The key approaches were strategic alignment. The phase pilot was strategically positioned to support a significant national educational reform. It was aligned with the national mandate from the National Medical Commission to implement competency-based medical education in all the medical school curricula in India. So the strategic role for FACE was to support the NMC's national mandate by providing essential professional development in competency-based education. And it has a potential for impact on medical education in India because it addresses a need for professional development and has the potential to impact the medical students from the 600 plus medical schools in India. So once we ran the pilot phase, we incorporated the feedback, modified the curriculum, and then launched it as International FAMER Competency-Based Education Program in 2023 from Philadelphia. The participants were nominated faculty who teach in the 10 FAMER regional institutes. What we did was we used a sustainable partnership model. through IFI and FRIs, which was used to scale up FACE globally. And thus we launched regional FACE in December 2023, which was launched by Christian Medical College, Ludhiana, FEMA Regional Institutes in India. And CMCLFRI is also going to celebrate its 20th anniversary. Participants were nominated faculty from the 4 FRIs in India. The RFACE curriculum was adapted from iFACE to fit the local context, promoting regional collaboration and mutual support. So very briefly, snapshots of the two programs from FEMA. So bridging the gap between global and local education starts with faculty development. If educators are trained to adapt global best practices effectively, they can transform medical education at an institutional and national level. So what it does is it equips educators with skills to adapt and implement global models, helps faculty become change agents in medical education reform, and strengthens teaching, curriculum development, and leadership. For example, a female fellow in India adapted CBME by integrating local patient cases into clinical training, making it relevant. So FEMA's approach doesn't just transfer global models, it tailors them to different regions through structured programs and fellowships. So how does FEMA customize global models to fit local needs? The first strategy is integrating global and local expertise for comprehensive curriculum development. International expertise provided global perspectives. So it leveraged knowledge and best practices from around the world, offers diverse viewpoints that enrich the learning experience, and introduces participants to global standards and innovations in HPE. While at the same time, local expertise contextualized the curriculum to local needs. So it ensured the curriculum is relevant and applicable to local context, addressed region-specific challenges and cultural nuances, engaged local professionals to tailor learning to the community's unique requirement. The second strategy is institutional partnerships, strengthening local ownership of global frameworks. What do I mean by that? This means that medical schools, universities, healthcare institutions, they actively adapt, implement, and sustain global education frameworks instead of relying on external organizations to dictate changes. So what FEMA did was it fostered local leadership and collaboration so that global best practices are not just imposed but owned, modified, and sustained by institutions themselves. So what are the different things that were done? Collaborative curriculum development. It works with institutions to co-develop its programs. We use the train the trainer model. Instead of one-time training, FEMA develops faculty leaders who train others within their institutions and the beyond, embedding best practices. Long-term engagement. FEMA fellows continue to work with their institutions beyond their training, ensuring ongoing curriculum innovation, not only in their institutions, but beyond their institutions. And there is potential for policy influences. Institutions working with FEMA can influence national policies. The third strategy is use of local cases and examples. So case scenarios and examples, for example, were used from Indian CBME undergraduate and postgraduate curriculum during the teaching learning sessions in the regional FACE program. The fourth strategy is strengthening local faculty leadership. It emphasizes a balanced faculty development approach, ensuring that local faculty lead the program with strong contextualization, while global faculty contribute select sessions for global alignment. For example, the regional phase was taught by local faculty who were trained through iFACE to ensure session materials were locally contextualized. At the same time, global faculty conducted one or two sessions as international guests to ensure global relevance. The fifth and the last strategy I would like to share is the project-based learning approach. So FEMA fellows that design and implement educational intervention projects within their institutions. They apply and adapt global best practices to develop projects that are locally relevant and contextually sustainable. Some examples of regional phase mini projects, you can see different things in EPA's, DRIFES model, integrated teaching model. But these examples are not the only ones that are Out there are many other faculty development programs around the world that are geared towards globalization. So the next question is, when do these strategies create impact? In this final section, we'll see how famous real-world impact, how faculty development, education interventions, and institutional collaborations led to sustainable improvements. The 20 plus years of experience with famous institutes has been published as open access a paper in academic medicine. The link to a 3-minute video abstract is available in the publication. It's open access, so it's free. And if you have not read it, I would encourage you to read this paper to learn more about famous institutes. So what I'm going to do is the data that I'm going to share in the next few slides is from this publication. Our data shows that fellows have self-reported an increase in knowledge, skills, and competence in the different domains of health professions, education, professional and leadership development, research and scholarship, and project management and evaluation. Similar results were found across all programs and between on-site and online formats. Projects are central in a FAMER fellowship. The primary focus areas has been consistent over 2 decades. However, some new project types have emerged, such as accreditation and interprofessional education and practice, which is rightly so. It is in response to the changing needs around the world. Projects have been institutionalized or incorporated into the curriculum as institutional policy. They have been replicated in other courses and settings and expanded to address additional objectives. Top institutional changes driven by projects have been increased quality and relevance of education and policy changes. Fellows have become leaders in health professions education, influencing national policies. They have contributed to creating or advancing HPE as a discipline. And with maximum number of regional institutes in existence for the longest duration and with maximum number of fellows, not surprisingly, India provides an example of major national impact. So growth, sustainability, and impact have been the 3 mainstays of the FAMER Fellowship. FAMER has developed a sustainable model to HPE and is an approach to globalization. So to conclude, throughout this presentation, we have explored how global best practices in medical education must be adapted to local contexts to create meaningful impact. We have seen how FAMER's approach through faculty development, institutional partnerships, and education interventions empowers educators to lead change in their institutions and beyond. So sustainable transformation in health professions education happens when faculty are equipped to integrate global innovations while addressing local needs. Take-home messages: global frameworks provide guidance, but adaptation is the key because one-size-fits-all approach doesn't work. Education models must align with local healthcare priorities, resources, and cultural context. Second, faculty development is the foundation for change. Well-trained educators drive innovation and sustain reforms in health professions education. Next, institutional partnerships strengthen long-term impact. So collaboration between local and global stakeholders ensures ownership, relevance, and scalability of reforms. Next is impact is measured by improved teaching, learning, and patient care. So success is not just in strategy, but in outcomes. Better trained faculty, engaged students, and stronger healthcare systems. And every educator can be an agent of change. So the responsibility of transforming health professions education lies with each of us by continuously learning, adapting, and leading within our own institutions and beyond. These are some of the references that I have used for this presentation. So the future of medical education isn't just about following global trends. It's about shaping them in ways that work for our communities. As educators, our role is to bridge the gap between global best practices and local realities to create a healthcare workforce that truly meets the needs of our patient and society. I will leave you with the closing question for reflection. What steps can you take to apply these insights in your own institution? What steps can you take to apply these insights on globalization in your own institution? Thank you very much for your patient hearing.
Thank you, Rashmi. We are indeed honored, and in fact, over the years, we have all grown through these steps uh, from FAMER to institutions, and you have nicely summed it up. And MEU India is honored to award you this Rita Sood Memorial Oration. Uh, Thank you very much for this session. And with this, we end this webinar. Thank you very much.